Good morning, Agarwal sir. Thank you so much for these very, very warm words of encouragement. And I especially enjoyed Dr. Lokwani's words because I think where I work in the field of coagulation, constant education is really the truth. So today, and I'm very, very thankful to the Mumbai Hematology group, which has invited me for this webinar today. I shall be sharing with you what I have learned about factor 13 deficiency while I have worked here in the coagulation lab at PGI Chandigarh. So factor 13 deficiency is a rare bleeding disorder and its frequency is just 1 to 2 per million. And in the last World Federation of Hemophilia survey in 2018, there were just 1,513 cases reported, out of which 117 were from India. I can just sneakily say here that there were 3 cases from our institute, which probably didn't enter the data, enter this database. But the woeful thing to be seen here is for our current population, we should be having at least 1,400 cases. So we could cover the entire WFH number of cases which they have identified last year with our population itself. So for as far as factor 13 is concerned, we are really looking at the tip of the iceberg currently. It's an autosomal recessive disorder and has a very high prevalence in consanguineous societies. And hence, we don't see it very frequently in the northern part of the country, but seems to be more frequent in the southern and the western parts. Factor 13 has a very important role to play in coagulation. It strengthens the fibrin clot. It promotes wound healing and is required to prevent recurrent miscarriages. The deficiency can be quantitative or it could be qualitative. It could be acquired or it could be inherited. But what really affects us, all of us who are working in the lab, is that it does not affect the routine coagulation screen tests. So we are totally dependent on our clinical colleagues that they have a high clinical index of suspicion and ask for testing for factor 13 when they think that there is a bleeding disorder. So where does the story begin? You're all familiar with this diagram, which shows the coagulation cascade. And the story starts with tissue injury with the release of tissue factor, which activates factor 7. And this complex then activates factor 10. Factor 10 activates prothrombin in the presence of factor 5 and in calcium. And the final effect of all this is to convert that soluble fibrinogen in the plasma to insoluble fibrin. So if we go closer, we will see where our factor 13 plays a role in this coagulation cascade right at the bottom. So thrombin has this and calcium, both of which are present in the plasma at the time of injury and activation, will activate factor 13. And this factor 13 does one very important thing. It converts the fibrin, which is loosely arranged as a mesh, into good, strong, cross-linked fibrin, which can hold platelets and can hold the red blood cells. So this is where factor 13 is required. So how does this cross-linking activity occur? If you look at the fibrinogen molecule, it is composed of 6 chains, 2 each of alpha, beta, and gamma. And these chains are arranged into 3 important domains: the E node, where all 6 chains are held together, and the 2 peripheral D domains, where there is 1 each of alpha, beta, and gamma fibrinogen. So when thrombin is generated, this cleaves off thrombin peptides, fibrinopeptides, and leaves the fibrin molecule. This is called the fibrin monomer. These fibrin monomers, they can combine with each other in a sort of a loose staggered fashion. The D domain of one can link to the E domain of another fibrin monomer, and so the chain can elongate. But this is loose. So if there is a strong chemical or a strong enzyme present in the plasma, this bonding can be broken. Here is where factor 13A comes. Factor 13A forms an important cross-link between the 2 D domains of fibrin monomers. This makes the bond extremely strong. It makes the clot resistant to lysis and even very elastic. Now, we know that once the fibrin is formed and it's performed its function of helping in the clot formation, very soon plasmin gets kicked off into action. And the job of plasmin is to cleave this fibrin clot so that the patency of the vessel is restored. So here, plasmin can cleave between the D and E bonds, but it can't cleave between the two D bonds. So we get our D dimer, which we measure in the D dimer assays and is currently a very popular test in COVID testing. So this is, D dimers can only be formed if there is factor 13A mediated cross-linking of fibrin molecules. So the factor 13 cross-links the two gamma chains, it cross-links the two alpha chains, and it can even cross-link alpha and gamma chains. Besides this, it performs a very important function. It cross-links inhibitors of fibrinolysis to this fibrin molecule to inhibit clot breakdown at the localization. So which are these molecules? It takes alpha-2 antiplasmin from the plasma and fixes it to the alpha chain of fibrin, again by a transglutamination reaction, and makes it available to clamp down the plasmin from breaking up fibrin too early. Similarly, it does the same thing for plasminogen activator inhibitor 1 and TAFI. As I've already said, cross-linking increases the strength of the clot and the elasticity of fibrin. And this allows it the clot to retain its RBCs and platelets. And the platelets, we know, will then form the platform for all the other coagulation enzymes to act and to make the nice fibrin meshwork, which will lead to plugging of the break in the vessel. Other than that, there is also intracellular factor 13 in platelets, which never enters the plasma. And this performs some really interesting functions. It causes cross-linking of actin and myosin in the platelets, so it's responsible for clot retraction. Now, coming to the factor 13 molecule, it's important to understand a little bit of what this is all about to see what kind of deficiencies we can expect. So this is a schematic diagram which shows that it's a heterotetramer. There are 4 molecules, 2 each of alpha and 2 each of beta. The alpha is the catalytic subunit which performs the transglutaminate reaction, and it's further composed of 5 domains. But the most important part of it is this chain-like thing, which is the activation peptide. This little activation peptide comprising of 37 amino acids is clipped off by thrombin to activate the factor 13 molecule. The B chains, which are at the sites, are like a cap, and they cover the active sites of the factor 13 and make it stable to be transported in the plasma. This ensures that the factor 13 in the plasma has a very long half-life, much more than most of the other clotting factors, which is nearly 12 to 14 days. So where is factor 13 synthesized and how is it transported? The factor 13 B2 units come from the hepatocytes. They are synthesized in the liver. And the factor 13 A2 units are synthesized by the bone marrow. So these are remote sites. And the cells who synthesize them are the monocytes, macrophages, the megakaryocytes, and the dendritic cells. And large quantities of factor 13 are stored in the alpha granules of the platelets. So it remains a very interesting question. Where do these two combine? This is secreted into the plasma, and factor 13A2 is also secreted into the plasma, but where they meet, nobody really knows currently. When these two combine, there are some recognition domains by which the A2 links onto the B2, and this tetramer is present in the plasma. But most coagulation enzymes are not allowed to travel like this in the plasma. They are supposed to be kept in a very controlled and checked fashion. So they'll piggyback on the fibrinogen molecule. This makes the factor 13 easily available whenever fibrinogen is to be cleaved and to form fibrin, so that it can quickly cross-link and perform its function. So what happens in the activation? This is our tetramer. As soon as fibrin is formed by the action of thrombin, the thrombin itself cleaves these activation peptides, and then the calcium in the plasma causes the release of the B domains, and now the catalytic domains are easily available to perform their functions while still linked to fibrin. In the intracellular part, there is no B domain, so it's the intracellular calcium itself which causes activation of the A domains. How does factor 13 deficiency present? So we all recognize it or know it as a bleeding diathesis, and in its severe form, it usually presents very early. And there's a very nice study by the NIH from Mumbai, where 37 patients with severe factor 13 deficiency were studied, and the age ranged between 1 month to 45 years. These were mostly referred cases from various parts of the country, with a very high degree of consanguinity in the families. Since it's an autosomal recessive disorder, this is not surprising. And the commonest presentations were umbilical stump bleeding, prolonged bleeding following trauma, and menorrhagia in females. The less common presentations are gum bleed and hematorosis. But why it becomes a very important factor that we should be all aware of is that it can sometimes cause fatal intracranial bleeding. Hence, it's important to be able to remember this in young infants who come with intracranial bleeding, that they may need to be investigated for factor 13 deficiency. I would take you through a couple of cases to show you various things that we can, which are written in the books, which we can learn from our patients. A 1-year-old female came with history of recurrent ecchymosis of the skin and had had one episode of epistaxis. She had bleeding from the umbilical stump on day 7 after birth and had needed fresh frozen plasma and packed RBCs. But there was no history of any recent transfusion when she came on this visit. And the screening coagulogram, as you can see, PT, APTT, and fibrinogen were normal. So whenever we are faced with this situation in the lab, we usually screen for factor 13 deficiency, and we keep it in mind that we might have to look for a platelet function disorder as well. So how can we screen for factor 13 deficiency? We have a very easy and a very convenient test called the urea clot solubility test, which is a screening test for severe factor 13 deficiency. The patient's platelet-rich plasma, platelet-poor plasma is clotted by thrombin or calcium, and then it is incubated with acetic acid or 5 molar urea for a day. If there is no factor 13, the clot is unstable, it breaks down in the presence of urea. This is likely to happen when the factor 13 deficiency is less than 5%. But if there's enough factor 13, then the clot remains intact. So the advantages are easy for all of us to see. Anybody who has a water bath and who has a pipette and who has tubes can easily do the urea clot solubility test. It doesn't need many reagents or equipment. But the disadvantage is that you'll know that your test is positive only after 24 hours. And it's going to become positive only if the factor levels are less than 5%. So it's not sensitive, and it's neither very specific, because if fibrinogen is low or abnormal, then this test will be falsely positive. And because it's not sensitive, it cannot be used to monitor replacement therapy. So coming back to case 1, in this patient, at the end of 24 hours incubation with urea, in the control sample, we can see that the clot is absolutely easily visible as this white ring just below the meniscus. Whereas in the patient, there is no such clot here because the clot was dissolved by the urea. A simple mixing study done on this patient sample on the next day showed that when we added 1 part of normal pooled plasma, the clot was restored. So this is actually a case of severe factor 13 deficiency. Now coming to the next case, this was a 28-year-old male who had a history of muscle hematomas, which had been noticed by him since the last 2 years. And he had gone to a number of hospitals before reporting to our centers. And all the doctors had correctly identified that there was a bleeding disorder, but the nature was not very clear. And that becomes very easy when we see the screening investigations. They were all very novel. So there was no reason to suspect a coagulation factor defect from these results. So as always, we did the urea clot solubility test, but that was negative. We ran the VWF panel, the antigen and the activity assay. These were normal. So when faced with this situation, the last thing we have with us is the platelet function test. We gave a date for that and ran that test also, which was normal. At this time, our hospital had just purchased a new coagulation analyzer on which we had the factor 13A antigen assay available. We had got only 1 kit for startup and we still had to make our complete order. So we were busy collecting all kinds of cases who were coming with whatever diagnosis to see how this kit would work. So 1 sample of this patient was also stored. At the end of 1 month, when we ran all the samples, we found that the factor 13A antigen level of this patient was 6.6%. So here was a patient with a bleeding disorder who had a negative urea clot solubility test, but had a low factor 13A antigen assay. So why was this? This patient had received a recent transfusion about 3 weeks back and still had some amount of residual factor 13A present, which was more than the cutoff limit for the urea clot solubility test, but was low enough to give rise to bleeding disorder. So this case taught me that the urea clot solubility test is insensitive to factor 13 levels below 5%. And if you are to work in a lab where you need to give a diagnosis, then you need some more assays. It also highlights that factor 13 usually has a half-life, because when we do testing for patients of suspected bleeding disorders, we usually tell them to come 1 week after their last plasma transfusion. And this is because most coagulation factors have very short half-lives. But factor 13 has a long half-life. So it continues to linger in the plasma much after 10 days. So we are likely to get a negative screen test. So it's wrong to just depend on this test to diagnose a factor 13 deficiency. So coming to the factor 13 antigen assay, this is not actually used for diagnosing, but it's used for classifying factor 13 deficiency. It identifies epitopes. There are ELISA kits, or the kits can identify the A2 antigen, the B2 antigen, or the A2, B2 antigens in their tetrameric configuration also. They can measure them in the plasma, they can measure them in the platelet lysate. And one is to resort to this test only if the factor 13 activity is low. And because this test gives information if the factor 13A or 13B is low. Currently, it's available in the ELISA formats, or the chemiluminescent assays, or the latex enhanced immunoassay formats. And it is now available on most automated coagulation analyzers. The advantage is that it has a very good sensitivity, and it's very popular because it's easy to do on your coagulation analyzer. It can identify nearly 95% of our patients with factor 13 deficiency, because most of them are due to a 13A subunit deficiency. The disadvantage, of course, here becomes that it's going to miss the rare factor 13B deficiencies, which amount to nearly 5%, and those qualitative deficiencies of factor 13A, which may have normal antigen levels. So what do we need to do if we have to really get to the diagnosis? Factor 13 is a 13 is a transglutaminase which acts at the last step of clot formation. So now our clotting times are not going to help, because that all ended when fibrinogen was found. We now need to look at a test which can measure the enzyme action. And we need a quantitative assay to decide how deficient it is. So the recommended first-line assays for this take us out of our comfort zone of coagulation laboratories, and we dive into the field of biochemistry, where there is an ammonia release assay, an amine incorporation assay, and an isopeptidase assay. Now coming to the ammonia release assay, briefly, the factor 13 present in the sample is activated using thrombin and calcium, the same two activators which are present in blood. Now, a peptide is present in the reagent which has a glutamine group, and this is acted upon by the factor 13 present in the sample and cross-linked by the transglutamination reaction. In this process, a molecule of ammonia is released, and this ammonia molecule is used to then reduce NAD or NADP to generate an indicator reaction at 340 nanometers wavelength. So the amount of ammonia released will be directly proportional to the amount of factor 13A present in the sample. So as you can see, it looks easier, and it is easily automated on a blood coagulation analyzer. It's a one-step test and very quick. You would get your diagnosis within 10 minutes. It's a true kinetic assay and has very good reproducibility. And some recent modifications on this assay can bring down its limit of detection to less than 1%, which makes it very good for severe factor 13 deficiency. The reference limit is 70 to 140%, and currently this is the gold standard assay for factor 13 functional activity. But the disadvantage here is that ammonia can be generated by other enzymes present in the plasma. Pepsinogen is one of them. And if we do not account for these, then in patients with factor 13 deficiency, if we just estimate the amount of ammonia released, we may overestimate their values. It's currently available as the Berichrome factor 13 kit on the Sysmex analyzers, and the Technochrome factor 13 assay kit on the Severon analyzer. So coming to the second method, which is amine incorporation assay. Here, a set of peptides is used, which contains again the same glutamine residue. And from the patient sample, there is factor 13, which can cross-link with this glutamine residue. This glutamine may be contained in a protein which may be casein or fibrinogen. So the basic protein there may be these. And to that is added a amine which can be labeled by a fluorescent method or by biotinylated technique. And by the transglutaminate reaction, this amine gets linked up to the glutamine of this peptide, and the factor 13 is released. So whatever unbound biotinylated amine is available, that is then measured using a streptavidin enzyme conjugate system and assay. This has the advantage of being a very highly sensitive assay, but it's very difficult to standardize. It's time consuming and is cumbersome and cannot be put on our analyzers yet. So, and the other thing is that there is sometimes a polymorphism present on factor 13, which causes a very rapid activation of factor 13, but not so good catalytic activity. So this may give us, mislead us into thinking that the factor 13 levels are normal. Now coming to the third set of assays, which are the isopeptidase assays. Here we utilize a peptide which contains glutamine, and this glutamine has an isopeptide bond which is linked to a fluorescent quencher. Next to the glutamine is any peptide which is linked to a fluorophore. And when it is excited, the fluorophore is excited, it can't release fluorescent light because of the presence of the quencher. But from the patient sample, if there is factor 13 present in it, it hydrolyzes this bond and the fluorescent quencher is released. So now the fluorophore is able to release light, which can be measured, and the factor 13 activity can be quantitated. The advantage of this assay is it can be automated, and this is definitely not affected by other ammonia releasing enzymes. So it's not going to lead to overestimation of factor 13 levels. But the disadvantage is that it has very poor correlation with the other ammonia, with the ammonia release assay especially in patient samples who have low factor 13 levels, the ones which are critical to us in the lab and in the wards. And it has a very low limit of quantification, which is 5%, whereas we need to go lower than this to pick up severe factor 13 deficiency. Currently, it's available in the Zadira kit marketed from Germany. So we have a urea clot solubility test which can screen for severe deficiency. We need to have factor 13 activity assays. These are important, but they are difficult and they're not easily available. The antigen assays are available in various formats and needed to subclassify the factor 13 deficiency. We do not really know how TEG can be used to help us in factor 13 deficiency because it's currently not standardized for this. I'm sure there will be studies which show us some patterns with which we can identify factor 13 deficiency by these techniques. So the ISTH therefore says that if you want to diagnose factor 13 deficiency, it's good to take an algorithmic approach. First, do a quantitative functional 13 assay. If it is normal, no further investigation. If it is abnormal, now you need to distinguish whether it is a quantitative or a qualitative defect. And for this, you need to assay the plasma factor 13 and the platelet factor 13, both the A, B, and the A2B2 subunits. So you really need a huge panel if you want to, actually get to the bottom of what kind of a factor 13 deficiency you have. If you're seriously thinking of inhibitors, then activity mixing studies have to be done, or binding assays have to be done for non-neutralizing antibodies. We need to verify the presence of factor 13 dependent fibrin cross-linking by STS page. And if you want to find the causative mutations, then genetic testing of factor 13A1 gene and factor 13B gene is required. So now, based on this, we can categorize factor 13 deficiency, the inherited form, into 13A or 13B deficiency, not by using the plasma activity and antigen assays of both A2B2, A and B subunits, and also the platelet activity and the platelet and factor 13A antigen assay. You remember that in the platelet, there is no 13B present, factor 13B subunit present. So in the factor 13B deficiency, everything is reduced because 13B is not present to protect the 13A. But the platelet has only 13A and that is not going to enter the plasma. So the levels of platelet factor 13 are normal. In the 13A deficiencies, there's type 1 and type 2. Type 1 is a quantitative deficiency where there is a reduction in the antigen as well as in the activity, but the B antigen seems to be more than 30%. In the type 2, there is a qualitative defect where the activity is reduced, but the antigens may be normal or may be low. So coming to the next case, we have a 32-year-old female who had recurrent ecchymosis and a single episode of hematuria. She had a history of cesarean delivery 5 years back, which was uneventful. She was referred for hematology consultation and the clinician suspected a von Willebrand disease. These were the kind of hematomas she had, one such on her shin. And the screening investigations revealed a normal coagulation screen. The VWF antigen was normal and the urea clot solubility test was positive. So this patient had a severe factor 13 deficiency. Now the patient herself did not tell, but she was also taking gynecology consultation for recurrent abortions. So we received another sample from the gynecology unit requesting APLA workup because that is one of the common reasons for recurrent abortions. And this sample was sent. The APLA workup was negative. So now the gynecologists would want to know if there was any other reason why this patient had recurrent abortions. So when we put the hematology work and the gynecology work together, we can see that there is a link between the two, and factor 13A is produced in the placenta in the labyrinthine layer, and this helps in the attachment of the placenta to the uterus. So factor 13, besides helping in prevention of bleeding, has a role in taking pregnancy to term. And the important part for us to know is that factor 13 is consumed during pregnancy, so the levels are likely to fall, and very frequent transfusions may be required. So the learning point from this case is severe factor 13 deficiency is associated with recurrent pregnancy losses along with bleeding. Coming to the fourth case. Now, this was a 10-year-old female child who was referred from a very young nephrologist from this hospital. She had she had abdominal pain, a skin rash, and renal failure, and had had 3 episodes of melena. The clinical diagnosis was henoch-Schönlein purpura, and she said that she wanted us to do a factor 13 assay because she thought of a factor 13 deficiency. I was very skeptical because I'd never heard of a factor 13 deficiency in this setting. And I said, okay, I'll run the screen. And we did the PT, APTT, and fibrinogen, and they were normal. We did the urea clot solubility test, that was also normal. The factor 13 assay, which showed normal values for that age. So according to me, there was no factor 13 deficiency in this. But this did set a ball rolling for me, and I thought it's worthwhile knowing which are the situations in which there can be acquired factor 13 deficiency. So there were many conditions listed in the literature. They can be antibody mediated, such as in SLE, malignancy, and in elderly folks. It can follow consumption, as may occur in major surgery, pulmonary embolism, in stroke, in leukemias, Crohn's disease, ulcerative colitis, henoch-Schönlein purpura, which was the current scenario, in liver cirrhosis, sepsis, and DIC. So there's a whole huge panel of acquired factor 13 deficiency, which we need to be aware of in the lab. In these individuals, usually the factor 13A subunits may lie between 20 and 70%. So I have labeled this patient as a case of no factor 13 deficiency, but there may be actually a functional deficiency of factor 13 here with normal factor 13 antigen levels. So the learning point for me from this case was keep an ear open for what your clinical colleagues say. Many times they will improve your learning and your understanding of a particular illness. So a 65-year-old male who was posted for cataract surgery was investigated and on history it was found that he had ecchymotic patches on the chest and abdomen. He had history of melena and hematuria of 2-3 episodes in the last month, but there was no family history of bleeding in this patient. He was not on any drugs which was could be responsible for unusual bleeding. The screening coagulogram was normal. The workup for von Willebrand disease was within normal limits. In fact, we had supranormal levels. The urea clot solubility test was positive. And when we did a mixing with the normal pool plasma, this test became normal. So looked like a factor 13 deficiency in an elderly male. The factor 13 antigen was low, but it wasn't good enough to be responsible for the bleeding. It wasn't, because most severe bleeds in patients with factor 13 deficiency occur when their factor 13 levels are less than 5%. So I really was in a quandary and wasn't sure why this was happening. I thought might as well look at the other things if there was any other contribution from a platelet function defect for this purpose. So we couldn't find anything. So this patient Probably what he had was an elderly male who had a recent history of bleeding with a positive urea clot solubility test and a diminished factor 13 antigen. This was probably an acquired factor 13 deficiency. Now, acquired factor 13 deficiency in the elderly could be autoantibody mediated. And the ISTH again gives us some criteria to classify them as possible, probable, or definite. In the possible, most of the criteria fitted our patient. It's usually recent onset bleeding in older patients with no family history of a congenital bleeding disorder, 13 or other, with lack of previous bleeding symptoms, especially to hemostatic challenges. This was not really clearly available in our patient, and not explained by excessive medication of anticoagulation or antiplatelets, and abnormality of factor 13 parameters. We had an abnormal UCS and we had a factor 13 antigen less than 50%. So this patient possibly had a factor 13 deficiency. What we needed to do was to check for the presence of inhibitors by mixing tests, but this needed to assay the factor 13 levels by a functional activity assay, which is currently not available in our setting. So we can just leave the diagnosis currently at possible. And definite is if we can prove that there are actually anti-factor 13 antibody present in the patient. So there can be neutralizing antibodies which neutralize factor 13A. This can happen before or after activation by thrombin. And these antibodies might limit the binding of factor 13 to fibrin or its cross-linking. And when we are faced with this in the lab, we need to run to check for a mixing study and see that it is abnormal. If that is so, then a Bethesda assay can be done for factor 13 using the a functional assay to quantitate it, for instance, the Berry-Chrome assay. And a niche measure modification is available even on this, like we do in factor 8, with using a buffering of the plasma for the incubation period of 2 hours and factor 13 deficient plasma to make the dilutions. There are other antibodies which are non-neutralizing. These just bind to the factor 13 and increase its clearance. And these usually bind to factor 13B or the tetramer itself, but may sometimes be targeted to factor 13A antigen. These can be detected only by binding assays. They would look like a deficiency, but it's only on a binding assay that these can be picked up. So if we have to look for neutralizing antibodies, our lab must have something to do to measure factor 13 activity and an antigen assay. Just using an antigen assay may underestimate the factor 13 levels. If we do both, with neutralizing antibodies, the activity is much reduced compared to the antigen, so this ratio is low. Whereas in non-neutralizing antibodies, both the antigen and activity are very much reduced, so the actual ratio between them may be normal. So coming to this table, which we have already seen partially for the inherited factor 13A deficiencies, for the neutralizing antibodies also, we can see that the activity will be showing a marked decrease. But when we have antibodies only directed against factor 13A, the 13B plasma activity antigen levels will be normal. So when do we need to resort to genetic testing for factor 13? The genes for factor 13 are present on 2 different chromosomes, factor 13A1 on chromosome 6 and factor 13B on chromosome 1. So this makes it quite challenging diagnosing factor 13 deficiencies. So you need to finish that workup of finding out where the problem is. Is it a antigen, A subunit defect, or is it a B subunit defect? Otherwise, it really becomes a very long exercise. And the inheritance is autosomal recessive. The severe disease is usually caused by compound heterozygosity on the 2 alleles, or when the defect is in homozygous form on both alleles. And most mutations currently identified are on the factor 13A1 gene. This is the catalytic gene, so not catalytic unit, so it's not difficult to understand why this is the problematic one. But recent papers are now showing that if we start hunting in the population for mild and moderate factor 13 deficiency, those individuals seem to have some more defects in the factor 13B gene. So we need more work on that before we say it's enough to look at only factor 13A1 gene in severe deficiencies. Unfortunately, there are no mutational hotspots for factor 13, so that makes it a little tricky for anybody who's planning to set up the genetic diagnosis of factor 13. In areas where there is high prevalence for factor 13 deficiency, say for instance, Iran, people have found founder mutations and they use RFLP or sequencing, an exon set of 1 or 2 exons, and they find this very cost effective and a time saving approach. In fact, it may be even recommended that in a family to go straight to the genetic diagnosis and then do the factor 13 assay. And because genetic testing is available, antenatal testing can also be performed using this information. There is some Indian data on the kind of mutations which are present in factor 13 deficiency, and I'm referring back to the paper I've already described before from NIH. The 37 patients whom they investigated, there were 25 mutations, a very nice wide number of mutations in 37 patients, out of which many were, at least 14 were novel. Many of them were missense mutations and nonsense mutations because this was a severe factor 13 deficiency. This picture may change a little bit if we look at patients who have moderate or mild deficiency. Now coming to the last case today, which is a 4-year-old female. She presented with recurrent skin bleeds and prolonged bleeding after trauma for 4 months. The mother had noticed an umbilical stump bleed after 10 days of birth, and she had needed transfusions at that time. She was of non-consanguineous parentage, and the screening coagulation tests, as you are now very familiar, were all normal. Screening for von Willebrand antigen and activity were normal. The urea clot solubility test was positive, and the factor 13 antigen was really low at 0.6%. So for all practical purposes, this patient had a severe factor 13 deficiency. My colleague in the Department of Hematology here at PGI has just been granted a fund for investigating the mutational spectrum of rare bleeding disorders in our North Indian population, with the purpose of making a small gene panel to use NGS as a screening method for mutation detection and to see its feasibility for antenatal diagnosis. So we had some samples stored, and this patient sample was also present there. And in the first run of NGS, which had a number of genes in it, including that for von Willebrand factor and factor 7 and factor 13, we ran this sample as well. And to my horror, in the first run, there was no mutation detected in either the factor 13A1 gene or the factor 13B gene. This was very demoralizing for the lab because for us, we had already labeled this patient on the basis of these two tests as a case of factor 13 deficiency. But what we did find in this patient was a mutation in the heterozygous form in the von Willebrand factor in the region which coded for the factor 8 binding site. So this patient was heterozygous for von Willebrand factor Normandy. Now, all these years that I have been working in PGI, I was waiting to see a case of of von Willebrand disease Normandy type, but I certainly didn't want it to come in this fashion. So this made me worried that there was a sample mix-up or something had gone wrong. But our research students, they are much younger and have much more, go and much more confidence. So they said, we'll resequence again and check. We may have overlooked some parts of the gene. In the meanwhile, we had the primers for von Willebrand factor because we were already looking at the type 2B von Willebrand disease. So the Sanger sequencing was done for this patient and for her mother, and both of them were found to be heterozygous for heterozygous at codon 2561 G2A, confirming that she really had a von Willebrand factor Normandy. The repeat NGS targeted sequencing was just done recently, and thankfully we now have a 4 amino acid deletion in factor 13A1 gene, which is homozygous and is novel, but the Sanger sequencing results and the family study is still awaited. So as we go delving deep into genetic testing of bleeding disorders, we're going to see that NGS may reveal hitherto unsuspected combinations of bleeding disorders. And I really don't know what role this von Willebrand factor Normandy heterozygous state would have to play in the bleeding manifestations in this child. So this is the last brief slide about the management. Because I work in a lab, I would request Dr. Agarwal to take on the questions related to management, but I do take this opportunity to share a little bit of what is available and what is known. The situations where we would need to give factor 13 would be prophylactic, because to prevent intracranial bleeds, in the perioperative situation where bleeding is expected, and in pregnancy. So the three Ps. And the hemostatic levels of factor 13 initially were written as 5%, but currently the European group feels that severe bleeds are less likely to occur when the factor 13 levels are at least 15%. In early pregnancy, at least 10% of factor 13 should be present to ensure good gestation. And at labor, this may need to go up to 20%. Most surgeries would require 50% of factor 13, but in those where a very clean operative field is required or heavy bleeds are anticipated, probably higher levels of factor 13 may be required by replacement therapy. What do we have available? Most of our Indian patients would have just fresh frozen plasma, which can be given as 10 milliliters per kilogram every 4 to 6 weeks. So the only saving grace is the patient has to come once in 4 to 6 weeks and is then relatively free from bleeding and protected against intracranial bleeds. Or we have cryoprecipitate, where one bag can be given for every 10 to 20 kilogram body weight every 3 to 4 weekly. Factor 13 is also available as plasma concentrates, fibrogamin and corifact, and there is a recombinant factor 13A also available. The factor 13 concentrates coming from human plasma may contain variable amounts of factor 13, and these are usually given IV in doses of 40 units per kilogram body weight to ensure that the trough level before the next transfusion is around 5 to 20%, which is the hemostatic range, and the doses need to be repeated every 28 days. But for us in the lab, so the clinicians are happy. They have some replacement to give for factor 13. But for us in the lab, there is a challenge here because the monitoring for these has to be done by a assay which is available currently on only one platform. So we need to monitor by doing the Berichrome factor 13 assay. So I'd like to conclude this talk by saying that challenges in the diagnosis of factor 13 deficiency appear at various stages. In the clinical diagnosis, you have to be suspicious. In the lab, you have to be running a lot of tests. If you do not take complete history of a recent transfusion, or you have taken a wrongly timed sample very early after transfusion, you may wind up in giving a false negative report. We have a cheap and easy screening test, but it is very poorly standardized and has very poor sensitivity. So though it is available to most of us, this is not a very good thing to use to diagnose factor 13 deficiency, other than its severe form. Activity assays are essential, and we all want them, but they are not routinely available on all common coagulation analyzers. Antigenic testing, which is now easily available, is required to characterize this deficiency, but is not good enough only to diagnose factor 13 deficiency. And genetic testing has an ethnic basis, and a country's database needs to be built so that we can plan a sort of algorithm for the genetic diagnosis of factor 13 deficiency. I'd like to thank you for your patient hearing, and I wish you a very happy New Year. Thank you.
Thank you, Professor Jasmina. With these 6 cases, it was a great talk based on your 40 years of personal experience. Everybody must be glued to listen to you. There was not 1 minute of boredom. From A to Z, you covered everything, and it was a great learning exercise for me, and I'm sure for everybody. We have some of the faculty members here, and I would like to ask them if they have some questions for you, starting with Dr. Jyoti. Till Dr. Jyoti thinks of a question, there's one question from the audience, that how do you sort of grade the factor 13 deficiency? At what factor level do you cut off mild, moderate, and severe?
So this is not, thank you for a question, and a very good one. And I'm so glad that you listened carefully and seen that I've not put it in anywhere in any of my slides, because there doesn't seem to be a very good cutoff for the grading mild, moderate, and severe. We're very sure that the severe factor 13 deficiency is less than 5%, but what really constitutes mild and moderate is not very clear. So I don't have a very good answer to give to you. All we can say is that severe should be less than 5%.
One small question is, does TEG pick up factor 13 deficiency, or is TEG abnormal in factor 13 deficiency?
I have no personal experience with TEG at all, and I'm sure that there are people in the audience in our learned faculty, including Dr. Jyoti, who may have seen factor 13 deficiency cases in this. But there is a problem in the fibrinogen, in the fibrin cross-linking and in the protection from fibrinolysis. So I do anticipate that there may be some abnormalities in the pattern. But I do not find too much literature saying that what exactly should be expected. And none of the guidelines add the TEG as a way of diagnosing factor 13 deficiency. So currently, I think because of the standardization issues, it would not be difficult, it would not be easy to make a categoric diagnosis of a factor 13 deficiency based on TEG.
Right. This
I
was
welcome comments from the faculty who have used this modality.
This was a question from Dr. Radha. Dr. Radha, it does affect the MA and the Lys60, but as Dr. Jasmina said, this cannot be diagnostic of factor 13 deficiency. We take up one question from Dr. Jyoti.
Yeah, there's this question that the screening test, as we do not have the functional assay available in India, and we can't follow the guidelines of the ISHTH, so we do the clot solubility test. So do you recommend that we should do two methodologies to increase the sensitivity and specificity of our clot solubility? Do the urea clot lysis as well as the acetic acid?
Some literature says that this would help, but I think that this would only work for our severe factor 13 deficiencies. And you're very right, we would need to not miss those cases, so this would help there. We personally do not use these two tests because many of our patients are transfused and they're going to have factor 13 levels which are higher than that, so we do the antigen assay. Yeah, so I mean, that's...
We are also doing the antigen assay, but as a screen where people do not have the facility to do the antigen assay in most parts of our country, they're just doing urea clot solubility. So doing a combination of urea clot solubility reading at 24 hours and 1% monochloroacetic acid at 4 hours, would that increase the sensitivity and specificity of at least picking it up?
Only for a severe...
We use that in our laboratory.
Do you do it?
Yeah, and that's what... Yeah, we are doing both. That's why I'm asking you.
Okay. So,
and there are cases we pick by one and not by the other. We picked up 3 cases of inherited and recently picked up 2 cases of acquired because we started doing more often in patients. So that's why
Thank
just
you.
Discussing it.
Dr. Subhaprakash can think of his question. Meanwhile, there is a question from the audience. This is related to other guidelines when to do factor 13 screen for recurrent miscarriages.
I'm afraid I don't have the answer to that question, but because we are not even very clear that how many recurrent abortions or miscarriages there would be before factor 13 deficiency is suspected. So where it's very clear for the APLA syndrome, that is not really available here. I think the data is very less. As awareness increases, probably we would know in how many miscarriages we should think of this.
Right. Dr. Naresh had asked this question. So these abortions are first trimester, and you know, first trimester abortions are left and right. 10% of the pregnancy, you'll end up with abortions. So the yield is very poor. So as a clinician, I will be guided by some history of bruising, bleeding, something happening here and there. Otherwise, you will end up with negative results for the whole year. Dr. Subhaprakash, your question, please.
Yeah. Madam, one quick question. Regarding the menorrhagia workup in the young females. So generally, we do the basic coagulation screen with the PTA, PTT, and the TT. And then if it is normal, then sometimes we go for the factor 13 assay with the UCS and then the platelet function and the von Willebrand workup. So if these 3 are normal, so can we now confidently label the no bleeding disorder, nothing from hematology, or we have to consider seriously about the factor 13A characterization?
So if we are going by the routine labs that we have here in the country, very few of us would have that entire panel which we need to characterize a factor 13 deficiency. If we are just sitting on a urea clot solubility test, then we are looking at only severe factor 13 deficiencies where I think there would be some bleeding manifestations present along with in the patient. But with 13A antigen, which is very easily available on the coagulation analyzers, we have a little more help. But we haven't really completely characterized anything which may be due to 13B deficiency. So I don't think, we can categorically say that there is no question of a factor 13 deficiency if we just do a urea clot solubility test and 13A antigen. Otherwise, I'm sure that in the guidelines, it would have been clearly said that all this testing is not required for menorrhagia patients. It is required for all our patients with bleeding.
Dr. Dipanjan, you can plan your question. Meanwhile, there's a question from the audience. Pre-surgical coagulation screen, should it include factor 13 deficiency screen?
I think the best thing would be history taking in a pre-surgical screen, and if there is history of bleeding, definitely then we would do a coagulation screen and look if there was no problem there. Then we would look at a factor 13, but not in every patient. It wouldn't be a routine thing to be added to a panel, because our screening test is very, very it lacks sensitivity totally. The case which I showed you of a 65-year-old male was going for cataract surgery, but only when somebody asked for history of bleeding and found that there were patches that we did the remaining workup. So not in every case, I think.
Thank you, Dr. Jasmina. That was very well said. It's extremely important. And as a clinician, what we follow is the routine package of the screen is platelet count, PT, PTT. So this is meant for patients who are clinically otherwise non-bleeders. But if clinically you suspect that there is even 1% chance of a bleeding diathesis, then you've got so many tests which have to be done. All factor assays, factor 13 screen, von Willebrand workup, platelet functions, so everything gets into that, not just factor 13. So yes, it's the history that is most important to guide you for the rare conditions. Dr. Dipanjan.
Thank you, madam, for the wonderful talk. My question is about factor 13 inhibitors. So, what is your experience in like with the urea clot solubility test as a screening test for factor 13 inhibitors? And like, is it sensitive enough to pick up these patients, like especially for elderly patients who are presenting with bleeding disorder? Or for them also, we need the complete factor 13 workup?
I think we actually need the complete workup, but what you can see is that the urea clot solubility test is a functional assay in a way. So if there is a neutralizing type of antibody which causes a severe decrease in factor 13 activity, then this test would tell us that there is a factor 13 deficiency. But as you can see from the guidelines, to say that there is an inhibitor there, you have to do a number of other tests to confirm that there is an inhibitor and it's an antibody which is inhibiting, which is currently not available to so many of us. Good to screen will tell you that there is a factor 13 deficiency, but whether it is an inhibitor related deficiency, it's difficult just by this test.
Thank you. Dr. Jasmita can plan her question. Meanwhile, there is a question. Is factor 13 concentrate available in India and what is the dose?
Agarwal sir, please.
So factor 13 concentrate has to be imported. There are guys who can import anything on the earth for you. So officially you can get it. The cost is exorbitant. We have the health minister of Goa with 2 daughters who got factor 13 deficiency and he was interested in this. Each dose, even if you give it once in 5 weeks, comes to in lakhs. So it is difficult for average Indian person. The dose is anywhere between 25 to 40 units per kg. Yes, question from Jasmita.
Good morning, sir. Ma'am, thank you for that excellent talk. Ma'am, traditionally, this is an underdiagnosed disorder in our country, and even now the diagnosis is hampered by this expensive kit. And so what has been your experience with mild or moderate cases? So patients essentially who are urea clot solubility test negative, but because you test them with the antigen, so in what percentage of cases have you found a positive yield? And the second part is that have you applied this test for diagnosis of post-operative bleeding where the screening tests otherwise are normal?
Both very good questions, Jasmita. I don't have too many patients where we went and found, factor 13 deficiency in levels which were which were more than 5%, except in the situations where I told you that
the post-transfusion
asked for. The clinician thought of it and asked us to do it, and we did it. In a routine where we are just getting patients with just bleeding symptoms where we don't find anything, we are running this test, but it never yields anything. So the factor 13 deficiency inherited for us is very rare. We get only 1 or 2 patients in a year, and this is a referral hospital. So I think we're just looking at the top of it. There must be more patients with mild and moderate deficiency in the population, which we can't pick up. The second question I think you're saying is this deficiency in the post-operative period. Not thought of by the clinicians again, so not being done by us too. Because as I'm telling you, the usual tendency is to just look at the clotting screen and go from that. If you have an abnormal PT, APTT, and platelet count, immediately the thought process starts running in consumption. So either DIC or not DIC. Factor 13 probably is poor factor lost in that conglomerate. But I'm sure if we ran the test, we might come up with surprises. There may be low factor 13 in these individuals. It's consumed.
Thank
Thank
you.
you, ma'am.
Last question here is, if you have an abortion in the first trimester, will you give cryoprecipitate replacement therapy throughout pregnancy?
Sir, could you take this question, please?
So answer is simple, yes. You cannot take a chance, though the maximum losses are in the first trimester, but you cannot take a chance. You keep giving it throughout till delivery takes place and after the delivery to take care of PPH. And as Jasmina said that the factor 13 goes down during pregnancy. So the recommendation is that you give it every 2 weeks, not every 4 to 5 weeks as you do in the non-pregnant situation. We have one family where the one son was lost with intracranial hemorrhage and the other son is absolutely fine, but his factor 13 level is less than 1%. The family is not interested in taking any chances, and every 5 weeks they're on replacement therapy for now donkey years. The patient is now about 30, 35 years old. He has been taking it regularly because they lost one son. They don't want any more problems. So I think that's the only time we have to cover these questions. We'll move on to the second lecture. Jasmina, extremely grateful to you for the talk and the questions.